Well, welcome to this pharmacology drug class review in the category of anti-diabetic drugs with a specific focus on the DPP-4 inhibitors. Now, this drug class is part of many other drug classes in the larger category of medications that give us as clinicians cost-effective options in the management of type 2 diabetes. In fact, I remember when this class arrived on the scene, when there really began that shift of preventing beta cell burnout, really started to gain its steam as it relates to the progression of the disease to lead us to our current options. And with that, I'm Dr. Busti. Thanks for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology, the drugs that we use every day. Because when you understand the why, the how becomes easier. Mechanisms start to predict those therapeutic effects, side effects, even monitoring parameters, and counseling points. Now, as with all my drug class reviews, we cover that core content. Make sure that we hit things consistently in a systematic method. So we cover agents, indications, uses, net benefit, why pick this drug class compared to something else, what is the pharmacology, considering pharmacokinetics and pharmacodynamic factors sometimes, and then transferring over to that clinical knowledge, pearls, things that you should know or must be aware of as you see and interact with these drugs in clinical practice, because no drug is perfect. All right, let's now dive into the agents, okay? We do have several in this class compared to other drug classes where maybe there are not. So when you see a lot of drugs in a drug class, that tells you something, that there's some value point that they offer. So dipeptidyl peptidase 4, DPP-4 inhibitors. Okay, we have Alogliptin, Linagliptin, Saxagliptin, and Sitagliptin. Okay, again, many of these have been around for quite a while. They are available in other combinations with other anti-diabetic medications like Metformin, pioglitazone, one of our TZDs, and then the SGLT2 inhibitor. So that gives us a lot of options for patients, adherence, compliance, things like that that they may need in real-world clinical practice. Now, moving on to indications and common uses for these medicines, okay? Straightforward, right? You're like, duh, type 2 diabetes, right? But it's an adjunct to diet and exercise. So they should not be used by themselves with no other interventions being made. Many times we forget and we ignore the diet and exercise part of it. When I say diet, I'm talking about medical nutrition therapy. Now let's move to that net benefit of the drug. Why pick it, right? Well, as you've seen, and many of you are aware of, the GLP-1 receptor agonists have really grown. And this drug is going to raise the concentration, or at least allow it to be present longer, because we're going to basically prevent it from being removed. Well, that's good. That has effect on the postprandial glucose in a glucose-dependent manner, right? Not just random and however it wants to, but it's a glucose-dependent manner. And in addition to that, there's a value of not causing weight gain, very low risk of hypoglycemia, and so it's not going to worsen the progression of the disease like secretagogues do. We'll talk about those in a minute, right? So this is the net value of the drug in the drug class. Now, moving over into the next section, which is really our pharmacology, where we start diving into mechanisms, and I'll talk about that a little bit more in depth, and then we're going to put it in the context of these drugs, again, the net benefit, and these drugs in relation to other classes, very basic level, so that you understand how they fit and apply in real-world practice. Now, this drug is affecting an enzyme, right? Peptidase, ASE, implies that that's an enzyme, right? So DPP-4 enzyme is responsible for the inactivation of incretin hormones, and there's two of them. Right? There's glucagon-like peptide 1, GLP-1, and then there's also, you see it two different ways. It's gastric inhibitory peptide or glucose-dependent insulinotropic polypeptide, GIP, right? Both of those are similar in what they do, right? But those are the two main incretins that are allowed to be around longer. So this drug is blocking the enzyme that would normally metabolize those things. And so what you're left with is it augments glucose-dependent regulation of insulin synthesis, glucagon release, and hepatic glucose output, also known as hepatogluconeogenesis. This is the one that metformin targets predominantly, okay? So you see some shared things that are starting to evolve if you ever study the history of this, and that's why this drug class is important, because it's not increasing the release of insulin from the beta cells in the pancreas, it's allowing the other systems to work more effectively in regulating glucose homeostasis and without burning up the pancreas and wearing them out. Pharmacokinetics considerations. So when we talk about kinetics, we're talking about absorption, distribution, metabolism, and elimination. So when we talk about metabolism and elimination, we think about metabolic pathways that these drugs could cause drug-drug interactions or that they need to be utilized in order to get out of the body. So there's two, right? So Linagliptin and Saxagliptin are at greater risk of drug-drug interaction potential, and that's due to phase 1 metabolic pathway cytochrome P450-3A4, because they're substrates of that. And many times something that is a substrate of 3A4 predictably, not 100%, but predictably are also typically substrates of P-glycoprotein, which is an efflux cell membrane transporter that moves things across cell membranes and gets them out of the cell. So it's an efflux cell membrane transporter. When you have drugs that block those, and they typically, if you have an inhibitor of P-glycoprotein, it's also typically, not 100%, typically an inhibitor of cytochrome P450-3A4, well then you could theoretically prevent the metabolism elimination of those two particular medications, and those would be appropriate things to know for a test question or board exams. Those kind of things are important but relevant in clinical practice. All right, now moving on to the clinical knowledge, clinical application piece, where we start to take some of that and continue to build on it, okay? And then reinforce a couple points that you need to just recognize. But overall, these drugs are fairly well tolerated, thankfully. They have a few issues, but fairly well tolerated. All right, so where do they fit? We got this big bag of anti-diabetic medications, and a lot of them with different mechanisms and ability to lower A1C. None of them are really going to get everybody 100% to their goals unless it's just except insulin, right? Insulin will get anybody at any glucose level, at any A1C to goal if you use the appropriate dose with diet and exercise. You can do it. But these agents are not all, they all have a limitation. And so that's why insulin is sometimes added, and we'll see that here in a minute. But the DPP-4 inhibitors are well tolerated overall, that's important, and usually considered second line historically, okay? The risk of things like, second line to metformin, especially when patients need weight gain, or they have weight issues or hypoglycemia, okay? So if those are of concern, then this drug class is helpful, right? One of the more common adverse effects is nasopharyngitis. That's not life-threatening, frustrating, irritating, but it's not life-threatening. And overall, this class is generally neutral from a cardiovascular issue, if that's what the totality of the evidence would suggest. However, there are exceptions with Alogliptin and Saxagliptin. You're seeing a little bit of a trend there. And as it relates to patients with heart failure, there are increased risk of hospitalizations in these patients. So it is something that has gained some attention that seems to be kind of isolated with those two. So you have the drug interactions, and now you have this heart failure thing. And I say possible because it doesn't necessarily prove causality, but there is a concern, and they've gotten some warnings about that. So considering the additional thoughts of where these drugs fit when we're affecting the gastrointestinal tract, the incretins, that's going to have an impact on our postprandial glucose levels. Okay, so if patients have postprandial glucose difficulty getting control, right, or they're at high risk for hypoglycemia, and they want oral therapy, these are good options. Okay, again, weight neutral overall. In patients with type 2 diabetes, that's beneficial. We would obviously prefer some weight lost, but remember, these are not working at the same level as the GIP, GLP drugs like tirzepatide and things like that, right? So some clinicians may prefer Linagliptin due to the lack of that renal and hepatic adjustments, but again, there is some risk for drug interactions. Okay, so thinking about the big picture of diabetes management. You know, these tables that I have available for you and then I've covered depending on, you know, where you're coming into this series of anti-diabetic drugs lectures that I do. I've used these tables in all of them and they're available at thisiswhy.health, but it's important to learn things in the context of the overall big picture of diabetes management. So we have type 1, type 2 diabetes here in each row, and the basic treatment strategies associated with that. So obviously with type 1, you have in type 2 where there's medical nutrition therapy and exercise. That is a baseline fundamental. Do not forget it. Secondarily, in type 1 is obviously insulin plus or minus pramlintide. Those are your main treatments. Okay? Now, I'm not going to get into the details of which insulin regimen, pumps, and all that stuff. That's a separate lecture. But type 2, after medical nutrition therapy and exercise, you see there are monotherapy or in combination with a non-insulin based regimen, right? So why non-insulin based? Because we want insulin it works very well, like I was telling you earlier, but the risk is that you could facilitate some weight gain as a result of using it. And so that's a problem when we have type 2 diabetes because they already have insulin resistance, metabolic syndrome risk. We don't need to worsen that. So, but when those fail, then you're moving to the addition of insulin, whether that's a basal long-acting or an existing non-insulin-based therapy, right? So we're starting to progress, and then we treat other comorbidities like thyroid disease. Now, when we start thinking about the anti-diabetic drugs and where this DPP-4 inhibitors fit, remember, so within the non-insulin drugs, we have secretagogues and non-secretagogues. The secretagogues are increasing the secretion and release of insulin from the beta islet cells of the pancreas. So drugs that turn on and stimulate the pancreas to do this at high levels, especially like the sulfonylureas, are going to facilitate beta cell burnout. I mean, you just get worn out. It's like running a marathon and you're like told to run faster at the end of it. You're just going to fall over. Right? Meglitinides, while they have a shorter half-life and don't stick around as long, they're also less effective, but they still will facilitate beta cell burnout. So where the non-secretagogue, non-insulin-based treatments, that's where the DPP-4s fit in that container. And so you see that there's a lot of them here, right? We have alpha-glucosidase inhibitors, amylin analogs, the big one are metformin, and here's your DPP-4 inhibitors right here, okay? And I've tried to list the classic agents there for you. So you could see them in comparison. What are the mechanisms like? How are they shared? How are they different? What is their primary focus? It's great for studying when you're learning this stuff at the beginning. These tools like this are very helpful. So again, you can download them, share them with your friends. Pass them around, it's fine. I made them for you to study and to help you. Right? If you're a faculty preceptor, use them, okay? So you see these, and you see a GLP-1s. These have grown. SGLT2 inhibitors, they've grown. We've got a lot of agents in these groups. But you sort of see where they fit, okay? And where kind of the bucket and why we would pick them. So if we want no to no weight gain, no hypoglycemia risk, compatible with metformin, that's a good option, right? Orally administered, there's not injections, all those kind of things. Now, when would we consider using them in patients with certain comorbidities or avoiding them with certain comorbidities? And so that's what this table is showing you. On the left-hand side, you have the medical condition like overweight, obesity, dyslipidemia, CKD, GI problems, gastroparesis, pancreatitis, and osteoporosis, those kind of things. And so let's look at the middle column, which is when would we consider this drug class if someone had a comorbidity? So again, trying to look for patterns of association, especially like on a question for an exam or board exam or in real world practice when you might reach in to that bag. So if you look up here for obesity and weight issues, the DPP-4, remember, are neutral. You're not going to use it for weight loss predominantly, but it's neutral. So it can be a consideration. It may not be the best consideration in those other options. I think we can all agree that there's better or more effective treatments, but it is an option, okay? Now, for all the other comorbidities, you really don't see it show up, right? Other than diabetes, right? But that's assumed. What about this last column over here on the right? So this is where we would use it with caution or just flat out avoid them, okay? So they show up in a couple places here. So if you have renal impairment, it says a plus or minus because it's going to be agent specific, so look it up, right? Heart failure, and remember the risk of hospitalizations. There's a possibility, it says plus, so it's a plus or minus, and it's Alogliptin, Saxagliptin in particular. Down here under the risk of pancreatitis, which I'll talk about here in a minute briefly, there's been concerns of it there. So you can see where you would want to avoid them. Pancreatitis and certain issues with heart failure, especially if they're being hospitalized or they have difficult heart failure that's not well controlled, and then patients with renal impairment, there is a small concern. All right, like I said, the heart failure, contraindications, warnings, that is one of its issues. So just keep that in mind. I've already kind of talked about that. Arthralgia. This can be disabling, arthralgia. There have been warnings now about it. It's gotten more attention, and it typically is reversible. But you need to recognize that if they start to complain, you need to warn them. It's a counseling point. It's also a monitoring point because this can be, they could assume something else is wrong. And then they would get a workup of MRIs and orthopedic evaluation and maybe injections and all this stuff that's unnecessary that we now expose the patient to, cost, risk, potential invasive procedures, all because of a side effect of a known cause of this drug. Pancreatitis, all the agents in this class have been associated with it, okay? And it may be as a result of an indirect result of the stimulation of these GLP-1 receptors in the pancreas, causing some degree of hypertrophy that would then obstruct the ducts leading out that empty the pancreatic enzymes into the intestine for you to use for digestion. So risk factors, patients with obviously significant or severe hypertriglyceridemia are already at higher risk, anything over 500 for certainly over 1,000. Cholelithiasis, alcohol use, patients who are obese, those would be additional risk factors that you want to keep in mind. There have been some dermatologic reactions, things from bullous pemphigoid to patients developing Stevens-Johnson's and TEN-like patterns. There have been even cases of DRESS, which is a drug reaction with eosinophilia and systemic symptoms, okay? It's thought that maybe the keratinocytes in the skin are expressing DPP-4 and are impacted by the drugs, and therefore they produce more cytokines as a result of that. And so that can happen, that has been reported. So monitoring parameters, you got the arthritis, you got the risk of pancreatitis, okay? You're watching their weight, A1Cs, those things make sense. The A1C is huge. Remember, we do not want to sit around waiting for them to get to their goal. You need to start to be aggressive at adding on therapy because these drugs are largely not going to get them to their baseline. Alogliptin has a small risk for hepatic injury, so just keep that in the back of your mind, monitoring AST, ALT, ALK phos in that patient scenario. All right. So these are the DPP-4 inhibitors. We got Alogliptin, Linagliptin, Saxagliptin, Sitagliptin. They represent drugs that are inhibiting the enzyme, specifically dipeptidyl peptidase 4. Okay. Remember, it's used for type 2 diabetes as an adjunct to diet and exercise. Side effects: arthritis, pancreatitis, maybe some skin reactions, generally neutral on weight gain, neutral overall in most cases for cardiovascular related issues. Historically fairly well tolerated other than a few of these nuances. So just keep those things in mind. So I hope you found that to be helpful in the context of the overall options of anti-diabetic drugs that you have available for managing these patients. Again, thank you for joining me. I hope that you found it to be helpful. Please join us on YouTube. If you haven't done so, again, please give us a like. We'd appreciate that. Identify the bell so you can keep up with new content, new topics. Again, join us at thisiswhy.health. Tell us what we can do. Share with me. Follow us on social media. We can try to serve you better. That's the goal, for us to learn. I spent 30 years doing all this. I want to share it and help, and I want to learn from you. So I'm Dr. Busti. Thanks for joining, and never stop learning the why, because it makes us, help us remember, retain it, and understand why we do what we do every day. That makes the how easier. Take care.